Dear colleagues, dear friends, the topic of today's presentation is ophthalmic electrophysiology, namely the methods of studying visual evoked potentials or VEP and objective Visus, their assessment, the mechanism of origin and the possibility of localization. These and other studies such as multifocal electroretinography, oculography, are carried out at the Terletska multifunctional diagnostic electrophysiological complex at the Institute of Eye Diseases named after V.P. Filatov in Odessa, Ukraine. At least 80% of information about the world a person receives through vision. Anatomically and physiologically, one can distinguish various subsequent levels of visual image processing. The visual process begins with the absorption of photons that enter the retina and contact with photoreceptors, rods and cones. Through cascaded biochemical reactions with complex pigment transformation, the process of phototransduction occurs in the photoreceptors, by means of which the light stimulus is converted into a neural signal, which follows to the bipolars and then to the ganglion cells. The axons of ganglion cells form the optic nerve, which is a bundle of myelinated fibers, which upon exiting the optic canal form a decussation, chiasm. Nasal halves of nerve fiber bundles intercross in the way that after the chiasm, fibers from the right temporal part of the retina and the nasal half of the contralateral left side go to the right geniculate body and vice versa. The formed visual tracts contain already mixed fibers which partially fall into the reticular formation and mainly into the primary subcortical visual centers, the right and left lateral geniculate bodies, where the signal is processed in the ventral and dorsal nuclei of the thalamus, consisting of meganocellular large neurons and parvocellular small neurons whose axons form the visual radiation. In the lateral geniculate bodies, binocular interaction of the retinas of the right and left eyes begins, and the primary processing of visual information takes place. The formation of pupillary reflexes, the separation of the signal from the noise, the contours of the object, its color and boundaries are determined. Graciolus visual radiance connects the thalamic centers to the visual cortex. According to Brodmann, these are fields from 17th to 19th. The primary sensory strial cortex, field 17, plays a major role in the formation of visual images. Neurons of this level form the entire visual field into separate quadrants, receptive fields, followed by an assessment of the position of the object and its characteristics. The functions of the visual cortex are the detection of a stimulus, the determination of its shape, localization in space, contrast, size, color, direction of movement, and the formation of a visual image. The perception of other parameters of the three-dimensional world is carried out with the participation of extrastrial areas 18 and 19, parietal 7, frontal 6 and 8, and other parts of the cerebral cortex. The joint work of the primary, visual and other listed areas of the cortex ensures the recognition of visual objects as well as visual attention, the performance of targeted actions under the visual control. Thus, a visual object seen by the eye in the form of an electrical impulse passes through the entire brain to the occipital cortex. A failure at any of the rings described above can be determined by registering this impulse, which in fact is the visual evoked potential. Visual evoked potentials represent the total bioelectrical response of large populations of neurons of visual cortex, thalamocortical pathways, subcortical nuclei, and retina to the impact of efferent light stimulus. VEP were first described by Adrian in 1941. In 1954, Adrian and Matthews reported that the electrical potentials generated by neurons in the central nervous system in response to visual stimuli could be recorded by electrodes placed in the human occipital cortex. VEP mainly reflect the electrical activity of the macular area due to its greater representation in the sphere groove compared to the periphery of the retina. There are different types of VEP: flash, reverse pattern, checkerboard or grid on-off pattern, chromatic VEP, multifocal VEP, topographic mapping. Let's consider flash VEP, which is practically the only method of choice when examining patients with low and corrective visual acuity, the inability to fix the gaze on the mark with cloudy optical media, poor understanding of commands, for example in newborns and children under 1 year of age. If necessary, the study is carried out in a state of medical sleep. In such cases, normal flash VEP are not evidence of presence of consciousness and visual perception, but only indicate the safety of non-specific ascending efferentation. Flash VEP provide generalized summary information about the state of the optic nerve, prechiasmal, chiasmal and postchiasmal disorders, because the entire surface of the retina reacts to the flash. Excitation passes through all the fibers of the optic nerve, and information processing occurs not only in the visual centers, but also in the pericentral structures of the brain, described above. Flash VEP contain early components with latency up to 100 milliseconds and late components over 100 milliseconds. In the literature, there are works confirming that the early components of P1 and 1 appearing on the 10th to 15th millisecond after the stimulus are due to extracerebral sources, namely retinal neurons. Prong P2 characterizes the conduction of bioelectrical potential from the retina to the brainstem, including the lateral geniculate body. The N2 wave, which occurs 20 milliseconds after the stimulus, reflects the conduction of the potential from the brainstem to the visual cortex, and the late components P3, P4, N3 and 4 with latency above 100 milliseconds are cortical responses. The rate of excitation conduction is directly dependent on the degree of myelination of the nerve fiber, the state of synapses and the mediator systems. The amplitude of the peaks depends on the number of unchanged neurons and the state of the axons in the pathways. Later, we will consider clinical examples with the assessment of bioelectrical functional activity of visual analyzer in various pathologies, in parallel with other research methods. In a number of cases, the study of flash VEP is used as an additional and demonstrative research method. So, following acute cerebrovascular accident, the decrease in the amplitude of components and the increase in their latency on the affected side of the brain compared to the intact hemisphere are found. In the diagnosis of brain tumor on the side of the volumetric process, signs of irritation are revealed in the form of an increase in the amplitude of flash VEP responses associated with an increase in epi activity of neurons in the focus area. With complete atrophy of the optic nerve, flash VEP are not recorded at all. Visual evoked potentials to reverse chess pattern or pattern VEP. The checkerboard pattern is a structured stimulus that excites the Kern apparatus of the central and pericentral zones of the retina with subsequent processing of information mainly in the projection zone of the macula in field 17 of the visual cortex. In the given graph is a variant of normal evoked potentials for pattern 1 degree. The M75 wave is the result of stimulation of the macula. The potential of the 17th field, according to Brodmann, is generated by the primary projection visual cortex. P100, the most clearly reproduced response component, characterizes the movement of the visual impulse in field 17-18, amplitude 10 microvolt and higher, and 145, the third wide negative prong. It is assumed to be generated by 18 and 19 fields according to Brodmann, the associative area of the visual analyzer. P200 is the next significant component, which is a negative wide dip generated by the subcortical nuclei of the thalamus and brainstem. Further, recorded sinusoidal oscillations are characterized by high variability, thus they are not evaluated in clinical practice. The amplitude time parameters of pattern VEP depend on many factors, from electrode placement, impedance, eye fixation, contrast, image brightness to cell size. The table shows the average values of latency and amplitude of components for different patterns in the known for different ages, according to the electrophysiological complex RETI scan in Odessa. The increase of P100 wave latency to 120-130 milliseconds indicates a slowdown in the conduction of functional excitation. The value of more than 120-130 milliseconds indicates organic changes in the visual pathway at different levels, such as demyelination, atrophy, dystrophy, malformation, etc., and allows to identify a significant pathology of the visual analyzer and other brain structures before the onset of clinical symptoms. The W-like form of the P100 component is evoked by an increase of the participation of perimacular structures in its formation and may indicate the partial atrophy of optic nerve, central scotomas, and focal lesions along the visual pathways. The asymmetry of the P100 latency index of more than 10 milliseconds is observed in the case of circulatory disorders in the vertebrobasilar basin. There are several distinguishing features of VEP analysis between children and adults. So in children up to 3-5 years old, the considered normal p100 latency is 115 and 125 milliseconds. With decrease in size of the chest cells, the latency of the VEP components increases in adults, while in children under 3-4 years of age, such dependence is not observed, which indicates the immaturity of spatial frequency perception in children. Another feature of the VEP pattern analysis is the decrease in the p100 amplitude, mainly by a large square, which is the indicator of problems with the peripheral part of the visual analyzer, the eye and retina. It also indicates the partial loss of axon's function or dystrophic nature of the process in the macular region, not excluding the lesion in another part of the visual analyzer. Moreover, the p100 amplitude may decrease due to poor fixation of the gaze on the mark, astigmatism and undercorrection. The significant difference in VEP components of two eyes during the monocular recording is an evidence of the prechiasmatic visual pathways dysfunction that may occur due to the pathology of the optical media, retina or optic nerve. For more accurate localization of chiasmal and postchiasmal visual analyzer lesions in both hemispheres, the topographic mapping method is used when the recording is made from two hemispheres in the presence of 6 channels with active electrodes and a common reference electrode. In the near future, we will apply the multifocal VEP program, which allows for more accurate localization of the posterior lesion in relation to two hemispheres, subcortical nuclei and the cerebral cortex. Indications for VEP: demyelinating diseases, in particular multiple sclerosis. Since the macular bundle of the optic nerve, optic tract and thalamocortical fibers are the fast-conducting myelinated axons, VEP can be the objective indicator of demyelination. Retrobulbar neuritis, injuries of the organ of vision, congenital abnormalities in the development of visual analyzer in children, in particular retinopathy of prematurity and amblyopia, ischemic neuropathy of the optic nerve, differential diagnosis of diseases associated with the physical damage to the optical apparatus or damage to the nerve fiber, brain tumors and vascular malformations with compression of the optic nerve or optic tract, atrophy of the optic nerve, decreased vision or blindness of unknown etiology, expertise, labor, military insurance, the presence of unusual complaints for a particular disease of the organ of vision. If a patient has a cataract or vitreous opacification, the complex registration of VEP and electroretinography makes it possible to predict the degree of preservation of visual functions and thereby clarify the indications for surgery and implantation of an artificial lens. Let's consider the characteristics of the VEP for some neurological pathological conditions. Epilepsy is characterized by fusion of several components into higher amplitude and longer lasting complexes with an increase in latent periods. The increase in VEP amplitude in epilepsy can be interpreted as a manifestation of general tendency of the hypersynchronization of neurons' activity and of the facilitation of afferent impulse conduction. In patients with severe epilepsy and frequent seizures, the decrease in the VEP components amplitude and the increase in their latent periods were found, which is probably associated with the use of sufficiently high doses of anti-epileptic drugs. It should be noted that in patients in the acute uncompensated stage of epilepsy, flash VEP is contraindicated. In traumatic brain injury, the increase in the amplitude of the late components of bioelectrical response is recorded. If a patient can see the mark, in the case of high-grade amblyopia, a moderate decrease in the amplitude of the potentials and a moderate increase in latency can be observed. With mild and moderate decrease of amblyopia, the indicators usually remain within the normal range. On the contrary, to the partial atrophy of the optic nerve when almost all indicators are changed. Pathological changes in the amplitude temporal parameters of VEP are detected in most patients with multiple sclerosis, even in the absence of any clinical signs of damage of the visual system. With the localization of a stroke in the occipital lobes, prolapse of pattern VEP occurs on the site of the lesion. Pattern VEP abnormalities joined with the intact flash VEP indicate limited damage of the fibers of the visual pathway coming from the macular area of the retina. When flash VEP change, the pattern VEP may remain normal if the neurological pathology is localized at a distance from the visual pathways, which should alert neurologists. In case of hysterical blindness or imitation of blindness, when the VEP for the pattern and flash does not differ from the norm, the objective Visus program is used to assess the patient's real state of vision. There is a correlation between visual acuity and the size of the checkerboard square of the reversal pattern. Thus, when visual acuity is not less than 0.3, the VEP pattern is registered per cell 10 minutes. At visual acuity 0.2 per cell 20 minutes. At visual acuity 0.1 per cell 40 minutes. This confirms the preservation of the function of neurons that conduct and perceive a signal of a certain spatial frequency. This principle was used when creating the objective Visus program. The program allows to evaluate the expected visual acuity by mathematical calculations by presenting black and white vertical stripes on the screen, gradually decreasing in width at a frequency of 7.5 Hz and with a contrast of 60%. The accuracy and reliability of the study depend on the correct fixation of the patient's gaze on the center of the screen where the stripes are moving. This method of cyclically changing the scale of a moving pattern allows to get a numerical value corresponding to a certain visual acuity. On these graphs, you can see how the regression curve with the values of the relative amplitude of the bioelectrical response within their confidence intervals is separated from the noise curve. At the point when the patient's visual acuity no longer allows to distinguish the bands on the screen, the two curves merge and the relative amplitude of the bioelectrical response drops to almost zero. This means that the patient is no longer able to distinguish between moving lanes and determines the maximum visual acuity that the patient is capable of. To some extent, the prototype of the method of objective Visus is visocontrastometry, where a sinusoidal contrast supply is used, but in objective Visus program, the result is not evaluated based on the patient's responses and the presence of optical nystagmus that occurs when looking at the table, as in the case of visocontrastometry. The detailed mathematical analysis allows us to get an accurate and quick answer about the patient's vision using the objective Visus program in the Retiscan electrophysiological complex in many difficult and controversial situations. Let me give you a few clinical examples demonstrating the bioelectrical characteristics of visual analyzer obtained by recording VEP in parallel with photographs and fundus fluorescein angiography of patients. Here we can see the male patient with sudden vision drop and visual acuity hand moving. The diagnosis is papillitis of the left eye. Color fundus photography showed papilledema with blurring border and macular edema. Fluorescein angiography showed hyperfluorescence of papilla in the late phase. The implicit time of N135 and P100 was strikingly delayed. The amplitude P100 was reduced 4-5 times, and bioelectrical response to 15-minute pattern is absent. And the next example, a 60-year-old female patient complained blurring of the right eye and the blindness in the lower field. Color fundus photography indicates blurring borders of the disc and a small slice of hemorrhage. Fluorescein angiography showed hyperfluorescence of the disc. On the pattern VEP, the amplitude of P100 is reduced and the waveform P100 is modified. If you have any questions, please send them to the comment section to this video. Thank you for your attention.